Dopamine is unique among the modulatory neurotransmitter because it projects discretely to the regions for motor activity, cognition, and emotional regulation. And in depression, dysfunction of these pathways contribute to the loss of motivation, diminished ability to experience pleasure, anhedonia, amotivation, and these symptoms are especially disabling.
Good evening, respected doctors. Today we are with our Dr. Rezaul Hamid, who is not only a psychiatrist but also a mental health entrepreneur as well as a researcher. He is here with the Cambridge Psychiatry Hospital, and now he is going to be more than 100 patients.
Thank you very much for so elaborative introduction. It's a great privilege for me to welcome you all to this great evening. I am truly honored for given this opportunity of addressing such an important issue, that is the importance of energy, motivation, and interest in depression. This presentation is going to be so overwhelmingly long, basically, but I will try to make it as short as possible. So I welcome all those participants I can see who have joined this evening, and this is a great honor for me to see all these learned individuals gathering out here. So I am starting. Niro, please confirm whether my full slide is visible. The first slide is the importance.
Yes, sir. This slide is visible, sir.
Okay. Basically, here I am going to talk on the concept of 21st century view of depression. And through this presentation, we'll be seeing numerous paradigm shifts in our understanding of what depression is. While we were doing our post-graduation, then we used to study about the monoamine theories of depression. And we have witnessed the changing of this idea of this monoamine theory. Then receptor downregulation theory we have come across. Then we have witnessed the understanding of neuronal plasticity that is being associated with depression. So now depression is recognized as a multi-level disorder, rather I should say not merely a serotonin deficit. And it has environmental factors, sleep, hypothalamo-pituitary axis dysregulation, and ultimately all leading to some form of impaired dendritic remodeling of the cells. And ultimately, at the molecular level, like BDNF, cyclic GMP, phosphokinase C, and all these kinases are seen to be involved in this causation of depression. And this depression arises from interplay across environment, circuits, cells, and molecules, and with neuronal plasticity at the center. And what the neuronal plasticity is, the previously as we used to thought that nerve cells once dead cannot regenerate. But in neuronal plasticity, what is seen as that in some areas of the brain like hippocampus and some other areas of the brain, this apoptosis and neurogenesis is a continuous process. That means nerve cell keeps on developing and newer branching. This is a continuous process, and that's what the theory of neuronal plasticity comes on. So in this presentation, we are going to see that depression is not just chemistry as we used to thought, but it is a disorder of plasticity and across levels of the brain. That's what we are going to witness in this presentation. Well, so here we focus on the complexity of antidepressant efficacy in major depressive disorder. And despite widespread use, the exact neurobiological mechanism remains unclear. And patients' responses vary widely. Diverse number of patients used to show diverse forms of response to antidepressant therapy, and some achieve rapid remission while other experience prolonged or treatment-resistant depression. That's what we used to see. And this underscores the need of personalized approach and further research into the brain network and changes associated with the treatment and other modalities of treatment that we are going to witness in this presentation. Well, so here we are going to conceptualize very few of the concepts. That is the 5 R's, and what those 5 R's is that there is a response. So we call it response when there is at least 50% reduction of symptoms, and remission means near complete recovery of function, and recovery refers to maintain remission that should be at least 6 months or more, and we call it relapse when the return of symptoms before the full recovery. We call it relapse. And while recurrence, we call it recurrence when there is the complete recovery between the 2 episodes. And this distinguishing between this recurrence is clinically is very important, as it informs whether continuation of treatment is required or long-term maintenance therapy is required. So the true success in depression is not the response, but it is the sustained recovery, and there should not be any form of relapse. Well, so here is about the monoamines, and these 3 monoamines, they are both anatomically and functionally interconnected. Serotonin modulates norepinephrine and dopamine release, and norepinephrine influences the serotonergic tone, and dopamine contributes to the motivational drive that serotonin and norepinephrine alone cannot sustain. And their interdependence explain the incomplete response when we used to target only one system, and reinforcing the need for broader pharmacological engagement in major depressive disorder. So depression is not just a network disorder, and if you target only one neurotransmitter system in isolation, then leaves the circuit incomplete. And we are going to have a deep dive into this fact and how we can address the various domains, various dimensions of symptom clusters of depression. Well, so these monoamines are linked with diverse types of symptoms. And if we see that specific domain, that serotonin, basically it regulates anxiety, impulsivity, and norepinephrine, again, it is responsible for sustained energy, interest, and dopamine, it drives motivation and pleasure. So together they underpin mood, cognition, and affect. And disruption in any one or more pathways produce the heterogeneity of depressive symptoms that we see, from anxious agitation to profound anhedonia, and that's what we are going to see. And mood is not driven by a single neurotransmitter. Depression is not the product of a single neurotransmitter. Basically, it is the orchestration of serotonin, norepinephrine, and dopamine together. Well, so energy, motivation, and interest are central determinants of the outcome of depression. What we are mostly concerned about, the outcome of depression. And patients with persistent EMI symptoms relapse more often and show very low rates of remission and carry a greater functional disability. And what we are concerned about as a clinician is that we need to put the patient to the previous level of functioning or highest level of functioning, or to a functioning that is better than the previous level of functioning. So if we target the functional recovery, it requires restoration of these domains and not just symptom reduction. And therefore agents that engages norepinephrine, dopamine in addition to serotonin are crucial in controlling these EMI symptoms. So if energy, motivation, interest are not restored, remission remains incomplete, and patient remains dysfunctional. Well, so this slide illustrates how depression reflects both reduction in positive effect and increase in negative effect, and is linked with distinct neurobiological dysfunction. On the left hand side, this reduced dopamine and norepinephrine activity within the dorsolateral prefrontal cortex, ventromedial prefrontal cortex, and orbitofrontal cortex, they manifest as a loss of joy, diminished interest or pleasure, that we call anhedonia, fatigue, decreased alertness, and reduced self-confidence. And on the right hand, we can see this heightened negative effect arises from serotonergic and noradrenergic dysregulation in overlapping circuits, producing guilt, anxiety, hostility, irritability, and social withdrawal. So taken together, these two dimensions emphasize that depression is not just the presence of sadness, but the absence of positive emotional experience, and effective management requires pharmacological approaches that can simultaneously reduce negative effect and restore positive drive. So depression is not only much negative emotion, it also a little positive emotion, and all these dimensions needs to be treated so that the patient gets a highest level of functional capability. Well, so dopamine is unique among the modulatory neurotransmitter because it projects discretely to the regions for motor activity, cognition, and emotional regulation. And in depression, dysfunction of these pathways contribute to the loss of motivation, diminished ability to experience pleasure, anhedonia, amotivation, and these symptoms are especially disabling as they undercut social and occupational function and persist even after the depressive symptoms improve. And this makes the dopamine dysfunction a central mechanism underlying the residual burden of major depressive disorder. So when dopamine falters, depression steals not just pleasure, but the very drive to live life fully. Well, as we know, these dopaminergic pathways, there are basically three important dopaminergic pathways. That is the mesolimbic pathway that is related with psychosis. But this mesocortical pathway is important for this regulation of emotion, and that we have to consider. Apart from nigrostriatic pathway that is related to motor function, there is another pathway also that is called the tuberoinfundibular pathway that is related to prolactin and lactation. This depression disables the very dopamine circuits that mainly, basically here the dopamine circuit that I am talking in front of you is the dopamine circuit that is linked with thinking, movement, and feel rewarded. Well, so most current antidepressants exert their effects primarily through serotonergic or noradrenaline system, which is SSRIs or SNRI, with little enhancement on dopaminergic transmission. That's the most important message this presentation is going to unleash in front of you, and this leaves dopamine-related domains like motivation, concentration, capacity to enjoy pleasure, and often insufficiently addressed. Evidence from the postmortem study, CSF analysis demonstrates that reduced dopamine metabolites in patients with severe depression, particularly in brain regions critical for mood and reward processing. And these findings explain why the residual symptoms persist in many patients despite partial improvement, and their dopamine deficit remains untreated. So these residual symptoms are often the dopamine fingerprint and left behind when serotonin, norepinephrine are treated, but motivation and reward remain impaired. And that is the most important deficit that lies with our patient, and we have to take it very seriously. Well, so this slide basically highlights an increasingly recognized subtype of depression and what we call the dopaminergic dysfunction. And these patients show poor response to antidepressant and that primarily target serotonin or norepinephrine with SSRIs, with other SSRIs or SNRI. So clinically, they are often the one who continue to struggle with motivation that we come across in our day-to-day practice, or drive, or the ability to enjoy pleasure, gratifications, despite adequate trials with SSRI and even with SNRIs. So the emerging consensus is sobering. That is, the majority of the depressed patients treated with standard SSRIs or SNRIs do not achieve full remission. And this reinforces the idea that serotonergic and noradrenergic modulation alone is not sufficient for many individuals. And dopamine-related circuits, particularly those governing reward and motivation, must be considered in both in research and in treatment. So when serotonin or norepinephrine are not enough, it is often the dopamine that is missing from the equation, and we should take it on board. Well, so the evidence here underscores the centrality of the dopaminergic system in depression. Its projection regions such as medial prefrontal cortex, nucleus accumbens, and striatum are strongly linked with depressive symptomatology. And in particular, the nucleus accumbens, long recognized for its role in reward and motivation. There have been many animal studies validating that and has gained increasing attention in understanding anhedonia in humans. So importantly, pharmacologic studies demonstrate that not all antidepressants act equally on these circuits. This is the most important fact. And sertraline and paroxetine both increases extracellular serotonin in nucleus accumbens more effectively than fluvoxamine. But beyond serotonin, acute administration of serotonin raises extracellular dopamine level in the striatum. And this dual serotonergic and dopaminergic effect influences the mesolimbic reward circuit, and which may account for sertraline's unique antidepressant profile, particularly to its ability to improve motivation and pleasure. So by enhancing dopamine in reward circuit, sertraline goes beyond serotonin and helps restore motivation and pleasure. So in subsequent slide, we are going to highlight how sertraline outperforms other SSRIs. Well, so sertraline enhances extracellular dopamine, and which translates into higher energy, improved motivation, and restored interest in rewarding activities. And those are crucial elements for true recovery, that is sustained recovery. So treating mood is not enough. So dopamine is what brings back energy, motivation, and the will to live, the will to do something. So SSRIs and SNRIs often fail to fully activate dopaminergic pathway, and explaining why it happens. And the true responders increases the T2 receptor binding in the striatum, and this is directly linked to the clinical improvement. And without dopamine engagement, the serotonin alone cannot deliver full remission. And that's why these partial responders on SSRI may actually represent the cases where dopamine circuit remains understimulated. So before branding someone to be resistant or non-responders, so identifying these patients at the early stage of the treatment, that means those with persistent anhedonia, low energy, amotivation, can guide a clinician towards therapies with dopaminergic activities, and such as that is the sertraline, and or adopting some other augmenting strategies. And this approach avoids the cycles of repeated SSRI trials with limited additional benefit, or increasing the risk of suicide, or keeping the patient dysfunctional for a long time. Well, here is how the residual symptoms And if you see, the residual symptoms are the most frequent barriers in achieving true remission. And in major depressive disorder, even after apparent improvement, patients often continue to experience sleep disturbances, fatigue, diminished interest, or impaired concentration. And these symptoms reflect the persistence of neurobiological dysregulation. There is something lie beneath, and this particularly within the dopaminergic and noradrenaline circuit, and that serotonergic agents alone may not fully normalize. And when we examine the 9 DSM-defined symptoms of major depressive disorder, it is striking that many of them overlap what we call the residual. Those are anhedonia, psychomotor slowing, low energy, cognitive insufficiency, and poor sleep. And the persistence of these symptoms contribute to impaired functioning, worsening prognosis, and sharply increases the risk of relapse. And for practicing psychiatrists, recognizing these residual symptoms are very essential because they often signal that the current therapeutic strategy is insufficient and even mood appears to be improved. And that is, the residual symptoms are the hidden burdens of depression and quite but very powerful predictor of relapse that we should appreciate at the early stage of the treatment. So, residual symptoms in depression are not just limited to mood alone, and these are insomnia, irritability, fatigue, and even physical pain. And these are not minor, and they signal incomplete recovery and increased risk of relapse. And the common symptoms, residual symptoms may present as backache, muscle ache, stomach problem, stomach ache, or diverse form of joint pain. And these are the patients who used to get exploited by doctors of other specialty, gastroenterologist, orthopedician, pain specialist. And we should appreciate this phenomenon and attend it very promptly. So this slide focuses on the prevalence and impact of residual symptoms in major depressive disorder. And sleep disturbance is reported by nearly half of the patients in remission. And fatigue remains close to 40%. Anhedonia, defined as diminished interest in previously pleasurable activities, is the third most common residual symptoms, affecting more than a quarter of the patient. And other residuals include anxiety, guilt, impaired concentration, appetite changes, persistent depressed mood, and while all contribute to the patient distress. And research shows that residual core mood symptoms, especially anhedonia and depressed mood, are the most detrimental. They exert a strong negative effect on functioning than residual anxiety, insomnia, or even somatic complaints. So clinically, this makes the anhedonia not just as a symptom, but a prognostic marker for poor functional recovery and increased relapse of the risk. So when anhedonia lingers, recovery remains incomplete, that we should appreciate, no matter how many other symptoms have improved. So we should always prioritize the symptoms of anhedonia. Well, so anhedonia, so as defined as the inability to experience the pleasure. The patient becomes unable to gain pleasure from the previously pleasurable activities, and it is the core feature of major depressive disorder. And yet neurobiologically remain incompletely to understanding. It is still a myth. While dopamine has long been suspected to underlie this reward-related deficit, empirical evidence has historically been inconsistent. We should know that. And nonetheless, the clinical burden is substantial. Nearly 37% of the patients with major depressive disorder clinically have significant anhedonia. And anhedonia particularly is a very challenging to treat because the first-line therapies such as SSRIs predominantly act on serotonergic system and which relieves sadness and anxiety, but fail to adequately address this motivational and reward processing deficit. So as a result, anhedonia often persists even after mood improvement, and making it a strong predictor for poor treatment response overall. This residual symptom is therefore not just another complaint, it is the central obstacle to functional recovery. So whenever the anhedonia remains, recovery is compromised, even if mood improves. Well, so anhedonia in mood disorder is increasingly linked to reductions in dopaminergic transmission. And preclinically, studies show that these neural substrates responsible for reinforcement and motivation, and particularly the circuits involving in nucleus accumbens and prefrontal cortex, and these are underactive in states of depression. And these studies have distinguished between wanting and liking. Wanting means actually which reflects the motivation and reinforcement, and it is strongly tied to dopamine activity. And in contrast, linking means the hedonic response to pleasurable stimuli, and it also involves opioid neuropeptides in addition to dopamine. And the fact that both systems are compromised highlights why anhedonia is a complex, difficult to treat, and unlikely to resolve fully with serotonergic therapies alone. So residual symptoms are one of the most important predictors of relapse in major depressive disorder, and longitudinal data shows that 76% of the patients who had residual symptoms at the time of remission and relapsed within 10 months, and compared to only 25% of those who achieved full remission. And this indicates the residuals are not just trivial, they represent the illness persisting in a milder form. So the clinical message is clear: residual symptoms must be treated vigorously rather than being accepted as good enough, and their presence signals the incomplete remission and warranting ongoing treatment for at least 3 months until symptoms fully subside. So partial remission and residuals should be regarded as an unstable state and time bomb clicking beneath, and this demands a very proactive therapy. And if left untreated, these symptoms increases risk of relapse, subjected to whenever the patient is subjected to some form of stress or some negative life situation. So residual symptoms are the bridge to relapse, and unless we close it, the patient will keep crossing back into depression. Well, so the residual symptoms are not beginning. These residual symptoms are not the leftovers. We just cannot leave it like that. Actually, they are the seeds of future depression if not actively treated. Well, so when residual symptoms persist, what should be our approach? This is the most important part. And though our newer classification systems have abandoned this multi-axis system, but in our day-to-day clinical practice, this is one of the most indispensable part, and it gives precision in our practice in evaluation and assessment. So when residual symptoms persist, the first step is to reconsider the diagnostic framework rather than immediately escalating pharmacotherapy or going to some other forms of therapy. We should see what lies beneath, and a structured axis-based review is helpful. On axis 1, we should see whether the primary diagnosis is correct, whether the diagnosis of depression is correct or something else lies beneath. Has an anxiety disorder, or this depression is of bipolar origin, or it is associated with substance use disorder. And we should also look in the axis 2, that is the personality disorder. Sometimes borderline personality disorder or avoidant trait may mimic chronic emptiness or low mood and yet respond differently to medications. And on axis 3, comorbid medical illness like various endocrine situations, neurological or chronic pain syndromes can blunt treatment response. Finally, in axis 4, we should see the psychosocial stressors such as financial strain, divorce, or any unemployment, those would lie beneath. So this systematic review ensures us to assess basically the residual symptoms and not simply masked sign of misdiagnosis or comorbidity or psychosocial driver. So it reframes the management to include psychological, social, and medical intervention alongside pharmacology. So not every residual is pharmacological. It may not be pharmacological. Sometimes the problem lies in diagnosis, comorbidity, or it may be due to other contexts. So this resistant depression means non-response to two antidepressant trials. And residual symptoms means partial responses with lingering deficit. And both are clinically important but require different management approaches. So not every partial responders may be resistant, and some may simply unfinished recoveries or with residual symptoms. Well, so the management of this residual depression is very crucial, and it requires a stepwise approach. So first of all, we have to ensure the adequate duration and the dose of the existing antidepressant, and when necessary, consider switching to another antidepressant. And secondly, integrating other forms of therapy, psychotherapies, particularly cognitive behavior therapy or behavioral activation, and these can address the cognitive and motivational dimensions that pharmacology alone may not be sufficient. And other forms of augmentation like adding lithium, thyroid hormone, folate, modafinil, and atypical antipsychotics such as aripiprazole. And fourth, we can go for polypharmacy with combining other SSRIs or bupropion or mirtazapine is sometimes employed in some cases. And electroconvulsive therapy remains often option for the severe and refractory depression. And apart from other advanced neuromodulation techniques like DDCS, RTMS, VNS, vagal nerve stimulation, these are evidence-based and found to be revolutionize the way we address the resistant form of depression. Though it is a completely different domain, not exactly related with the discussion on the pharmacology, we may have some other discussions on how neuromodulation is revolutionizing the treatment in psychiatry. I just can, in a single word, I can say that we are voyaging into avoiding pharmacological intervention for many situations in mental health. Well, so in practice, the sequence of these steps varies to psychiatrist to psychiatrist and often tailored, often based on the patient profile, comorbidity, and clinical judgment. The psychiatrist judgment is the most important, and this flexibility undergoes the art. Basically, this is actually art and as much as science of managing the residual depression. So the residual depression demands persistence. It demands optimization, it demands augmentation, it demands combining, and when necessary. Well, so this is the treatment paradigm, and this how it evolved towards normalization of the functioning, basically. And this slide illustrates the evolution of treatment goals in depression. And historically, the focus was on reducing the symptoms, with success defined as significant mood improvement. The next step was improvement of symptoms, and that is quantified as 50% reduction of depressive scores. While important, and these milestones often left patients with lingering impairments. The modern paradigm has shifted towards remission, and that is achieving symptom level indistinguishable from a healthy control. That's the most important concept. But even remission is no longer enough. The ultimate target is functional remission, that is the functional capability of the patient, and where the patient just not only feel better but begin their motivation, cognitive performance, productivity, social connectedness, and overall quality of life. And measuring this requires tools, those are beyond symptom scales such as assessment of energy, cognition, and role functioning. And this paradigm reflects a holistic goal, that is the normalization of functioning, and not merely reduction of the distress. So the true endpoint of treatment is not fewer symptoms, but it is the quality of life, the functionality of the patient. Well, so here is about Sertraline for EMI, and many patients with depression continue to struggle with residual symptoms, and particularly those tied to the brain's reward system, and they have impaired pleasure, they have reduced motivation, they have low energy, and these symptoms point to dysfunction basically in mesolimbic circuit. and especially in nucleus accumbens and ventral tegmental area. And these are the critical for motivation and reward processing, because anhedonia, reduced drive and low energy, and so central in depression. And because they are often resistant to serotonergic treatment alone, and there have been growing interest in antidepressant with dopaminergic properties. And among SSRIs, sertraline is unique, and it is the only one shown to inhibit dopamine reuptake in vitro, and this dual action on serotonin and dopamine makes it a rational choice for patients who remain who still have complaints of low energy, no motivation, no interest, as the very domain of today's discussion, that is EMI, energy, motivation, and interest. So sertraline is the SSRI that resets the reward system, and it makes it uniquely suited for EMI symptom. So we are almost at the end of this presentation. This is already have been so overwhelmingly long presentation that I already have told in the very beginning. So this slide demonstrates how preclinical mechanistic findings translates into clinical outcome with sertraline, and that is on the bench side. If we see, sertraline show improvement in Hamilton Depression Scale scores as early as 3rd week, and prevents recurrence beyond 18 months, and binds more strongly to the serotonin transporter compared to escitalopram. And it also enhances functional connectivity between the hypothalamus and dorsolateral prefrontal cortex. And most importantly, it acts on sigma-1 receptor. And this is a sigma-1 receptor agonist at low doses and increases extracellular dopamine level. And these properties suggest the broader neurobiological engagement than purely serotonergic agent. And on the bedside, if we see, this mechanism translate into the predictable clinical efficacy and tolerability. If we see the clinically, the patient can often experience early anxiety reduction followed by mood improvement. And sertraline has the robust evidence for maintenance therapy and chronic depression, supporting long-term use, and cognitive deficits are also seen. So including improved working memory and executive functioning. Importantly, its dopaminergic action may improve anhedonia, low motivation, and energy deficit, aligning with the goal of functional remission. So from lab to clinic, sertraline stands out its unique biology, and that translates both from symptom relief and functional gain. Well, this has been adopted from Stephen Stoll. So this sertraline's pharmacological profile extends beyond serotonin reuptake inhibition, and low dose, it can act as sigma-1 receptor agonist. The sigma-1 receptor is basically a chaperone protein. This is involved in neuroplasticity, that is the cellular resilience and modulation of neurotransmitter system. And what is that neuroplasticity? That these gets executed with the production of brain-derived neurotrophic factor. It causes the neurons to outgrow dendrites and connecting with other neurons. So by engaging sigma-1, sertraline influences not just serotonergic but also the dopaminergic pathway, contributing to a more balanced neurochemical effect. So clinically, this translates into benefits for energy, motivation, and concentration, and these domains that are often resistant to SSRI, without which this activity. So compared to escitalopram, which is a pure serotonin reuptake inhibitor, sertraline's additional sigma-1 activity may partly explain this broader efficacy for patients with residual symptoms and cognitive symptoms, and how it happens, because when it produces more BDNF, there is more offshooting of the neurons and more connectivity increases. Basically, it increases the RAM of the brain. That is a random access memory of the brain, as we have in our computer. When you increase the RAM, the processing power of the computer increases. A similar sorts of neurobiological phenomenon happens, and that has been scientifically proved. So sertraline sigma-1 action makes it more than an SSRI, and as it is the modulator of energy, drive, and concentration. Well, so So switching antidepressant is a very common when patients fail to respond to initial SSRIs therapy. But not all SSRIs are equivalent, that I'm repeatedly telling. So unlike paroxetine or fluvoxamine, sertraline has the unique ability to increase extracellular dopamine in nucleus accumbens and striatum at therapeutic doses. And this property is linked to its affinity for the dopamine transporter, and which enhances the efficacy in more severe and resistant depression. So clinically, this translates the improvement in anhedonia, reduced motivation and low energy, and domains that left untreated by other SSRIs. So by engaging mesolimbic reward circuit, sertraline provides a unique antidepressant effect, making it a more rational and rational switching option when patients fail to improve with paroxetine or fluvoxamine. So when SSRIs fail, sertraline's dopaminergic action can reignite reward and motivation. So this sertraline maintains remission and prevents relapse. So long-term outcomes are very critical in depression management. And in this slide, this slide highlights sertraline's advantage in relapse prevention. Over a 2 to 5 year follow-up, patients on sertraline showed the highest proportion of relapse-free survival compared to escitalopram, paroxetine, venlafaxine, fluoxetine, and bupropion. And especially 69% remain relapse-free at 2 years and 61% at 5 years. This shows the outperforming with other comparators across both timeline. And additionally, patients on sertraline spend on the lowest proportion of treatment time in relapse, that is the 8% compared to 12 to 15% for the most other agents. And this reflects not only the sustained efficacy but also consistent with long-term stability. For clinicians, these data underscore sertraline's role as a reliable maintenance agent, particularly for patients at high risk of recurrence. So sertraline is not just for getting patients wellness, but it is for keeping them well also. Well, so long-term data show that sertraline offers a powerful balance between rapid remission and durable relapse prevention. So sertraline helps patients get well fast and stay well for years. Well, so this is the SMILE 2 trial, and this explored how antidepressant therapies and exercise affect the cardiovascular risk in patients on major depressive disorder. And over 200 adults were randomized to supervised exercise, home-based exercise, and were getting sertraline 20 to 200 milligram per day or a placebo for 4 months. And result was astonishing. And it shows both supervised exercise and sertraline improved vascular health and flow-mediated dilatation, and that is a marker of endothelial function, and was significantly higher in the sertraline and supervised exercise group compared to placebo. Likewise, atherosclerotic cardiovascular risk scores were lowest in sertraline and supervised exercise arm. And this highlights the parallel benefit. And initial, the tunica intima media thickness were also improved modestly, and this reinforces the vascular protective effect. And this is the key conclusion, is that both the exercise and antidepressant medications can only treat mood but also reduce cardiovascular risk in depressed patients. This is the most important find of this study, and this underscores the dual effect of sertraline, and effective for depression while improving the physical health outcome in population at risk on heart disease. And apart from that, the sertraline is also having antiplatelet effect. And if you see about the patients of cardiovascular illness or cardiodiabetic illness or metabolic illness, the prevalence of depression is around 40%. So had sertraline been integrated with the basket of these metabolic disorders, it increases the patient well-being, and also it increases the compliance of the patient. How it complies the patient? Because it protects from the depressive symptoms, those hopelessness, helplessness, life to be worthlessness, and no motivation, and losing the motivation to take medication. So treating depression with sertraline, so it does not just heal the mind, it protects the heart also. Well, so the SMILE 2 trial, this provides the compelling evidence that treating depression has benefits beyond mental health. this compared to placebo. And active treatment, whether supervised exercise, home-based exercise, or sertraline, was associated with measurable improvement in coronary heart disease risk factor. And these included the reduced progression of carotid plaque formation, then improved endothelial function, and a significant reduction in 10 years, that is atherosclerotic cardiovascular disease risk. So importantly, this trial highlights that since major depressive disorder itself is an independent risk factor for cardiovascular disease or other cardiometabolic disease, this addressing depression with a structured treatment so not only restores mood but may directly reduce the cardiovascular risk. So both exercise, sertraline, and therefore serve as an intervention as the intersection of psychiatry, cardiology, and reinforcing the principle of integrated care. So in SMILE 2 study, exercise, sertraline both improved vascular health, and it reduces progression of intima media thickening that is consistent with atherosclerosis, and it lowers the atherosclerotic cardiovascular risk. So treating depression is also treating the heart disease risk. So when you treat depression with sertraline or exercise, it also protects the heart from the future disease. Well, so this study examines the safety and efficacy of sertraline in elderly patients. We are almost at the end of this presentation. Apologetic for this long stretching nature of this presentation because the topic is so vast and complex. Well, so with moderate to severe major depression, particularly those with comorbid vascular disease. So the population included the subgroup, the patient with hypertension but no other cardiovascular diseases, and those with a history of cardiovascular disease excluding hypertension, and those with any vascular comorbidity. And one important observation is that the elderly patient with vascular comorbidity were often on an average of 5 concurrent medications, and making this drug interaction safety is very crucial. This sertraline demonstrated the efficacy in improving depressive symptoms while maintaining a favorable safety profile across these subgroups because it is metabolized by cytochrome P450 enzyme system. Even those with multiple comorbidities, where the polypharmacy and this group of patients actually they used to get multiple medications, and this is the metabolically safe. It has no other serious form of drug interactions. And so even in elderly patients with multiple vascular comorbidities and polypharmacy, sertraline delivers efficacy without compromising the safety. Well, so in elderly patients, particularly those with vascular comorbidities such as hypertension, safety and tolerability are the clinical factors, and when choosing the right antidepressants, this is the sertraline was well tolerated. No higher rates of side effects and continuation compared to control. So sertraline is safe, well tolerated, and effective option for depression in elderly patients and even those with vascular comorbidities. Well, so advantages. So the depressed patient have low brain-derived neurotrophic factor, that is the BDNF that I was talking about. Had time been given to me at last, I would be talking on this brain-derived neurotrophic factor, how it is manufactured inside the neurons, and this BDNF is linked with worse symptom. And sertraline raises BDNF, that is the brain-derived neurotrophic factor, that is within the 5 weeks of time, that is the faster than venlafaxine or escitalopram. This is the most important factor. It is supporting its role in neuroplastic recovery. So in just few sentences, if I talk about the BDNF, that is the brain-derived neurotrophic factor. So as we know, whenever the molecule gets attached with the receptor, it gives signal downwards with cyclic AMP and cyclic GMP inside the cell. So these basically a cascade of reactions set on, and this ultimately activates the genome. That further starts some cascade of reactions that causes production of mRNA, rRNA, and tRNA. So new templates are being formed and new proteins are being synthesized. Protein synthetic system inside the cell produces some lytic enzymes and BDNF. The lytic enzymes are stored inside the vesicle, they come outside the nerve cells and causes lysis of the receptors, and simultaneously they produce the brain derived neurotrophic factor, the BDNF, and this BDNF is attributed to the clinical improvement in depression. This BDNF comes outside and this activates, stimulates the cell to make more and more branches and connecting with other neurons, thereby increasing the connectivity, thereby it increasing the random access memory of the brain. And this phenomenon is consistent with brain-derived neurotrophic factor, BDNF. This is how the signal inside the cells are given. So this is the explanation of how the BDNF is produced and how the antidepressant action is being exerted. And in this point, if I give you the example of tianeptine, that is an antidepressant which is a serotonin depleter. So ultimately the antidepressant actions are exerted with production of the BDNF. This is one of the most important explanation of how this BDNF is related to sertraline or with fluvoxamine. Thank you very much for bearing with me with this overwhelmingly long presentation. It's my great pleasure to present this presentation in front of you. And to all my audience, had there been any question, you can put in the chat box. I'll be trying my level best to address your queries. Thank you very much.